Good afternoon, everyone, and welcome to today's webinar. As we are getting started here this afternoon, as we often do, we would like to start by asking our audience a polling question. Today, our polling questions explore inequities in employee benefits. So benefit inequity occurs when, intentionally or not, different groups of employees experience disparities in the access, quality, or value of non-wage compensation. So things such as health coverage and other employer-sponsored benefits. And we are curious about your organization's perspectives on this topic. So please take a moment and provide your responses as we get started. And note, we do have two polling questions. You may need to scroll down to see both polls. And as you are responding to those polling questions, I would like to again welcome you to today's webinar. I am Jenny Bedeau with Assurex Global, and today the Lumelight team will be doing some spring cleaning and will be providing a compliance checklist and regulatory update. And we would like to extend a special thank you to your local benefits advisors and consultants who are partners of Assurex Global for making this webinar series possible. We do always welcome your questions during these webinars. If you do have questions at any time throughout our presentation today, you can submit those over to us using that Q&A function at the bottom of your screen. We will address as many questions as time allows. And if you are just joining us here today, you should see a couple of polling questions up on your screen. Please do take a moment and provide your responses. And I also will mention our session today is being recorded. The recording and the presentation slides will be available early next week from the benefits advisor who invited you here today. And I will also drop a link to the presentation slides in our chat section here in just a couple of moments. And I will keep the polls open here for just a few more seconds here. It looks like we still have a few responses trickling in, and we want to capture as much feedback as possible. And as I am capturing those last few comments, or excuse me, those last few responses, I'll also mention we do have two polling questions that we're saving for the end, also on the same topic, just a different perspective on those questions. So we want to make sure you stick around for the last couple of minutes as well. Okay, and I will give it just a second here and I will share the responses out with everyone. Okay, so you should see the responses here. I know this is a topic that's been discussed more or maybe over the last couple years than we had maybe heard about it before. It looks like many of you are saying, hey, we aren't seeing many meaningful inequities, but those of you that are, you're seeing some really with those lower paid versus higher paid employees and maybe some with those chronic versus healthy employees. And for those of you answering, is improving benefits equity an explicit goal? It looks like many of you have considered it and maybe discussed it, but it's not an explicit goal. So thank you again for answering those questions. And again, stick around. I've got two more related questions at the end. But for now, let's get into today's content. Joining us today from the Lumelight team, we have Regan Debben, who is Director of Compliance Consulting, and Delaney George, Compliance Consultant. Delaney, I'll hand it over to you.
Thanks, Jenny. Okay, to start us off today, like Jenny said, we're looking at some spring cleaning items, whether that's upcoming deadlines or things that are just needed for ongoing plan compliance maintenance. And then we'll wrap up with some potential and upcoming compliance changes to keep your eye on. So with that, we will start with some upcoming deadlines. Firstly, I have a timeline for both upcoming and very recently passed deadlines on the screen. First thing to note is that this timeline is only going to be very strictly, completely applicable for calendar year plans. As noted by the asterisks, there are a couple deadlines here that are connected to when your plan year is. So for the creditable coverage disclosure, which is always due within 60 days of the beginning of your plan year, if you do have a calendar year plan and maybe that hasn't been done yet, highly encourage you to get that done. Just largely because there is no specific penalty for a late filing there. So there's really no reason not to. The other deadline connected to a plan year is going to be your Form 5500 filing, which is always due at the end of the seventh month after the end of the plan year. But for the rest of these deadlines, though, these will remain the same. They'll be static, regardless of when your plan year is. So Form 1095s need to be distributed to employees by March 3rd for any applicable large employers or self-funded plans. With the submission to the IRS due on March 31st. Then we have RxDC reporting for the 2025 calendar year due on June 1st coming up. However, as noted, in all likelihood, there may be a service provider or plan vendor, whether that's a carrier or TPA, that may be helping to take care of that reporting requirement for your plan. But in order to do that, there is some information that the provider needs to collect directly from the plan or the plan sponsor. And so what that carrier or TPA will do is send out an email or request asking for that information from the plan, and then have their own deadline saying if the information is submitted by a certain date, then they'll be able to take care of that RxDC reporting for the plan. And what we've seen is that carrier TPA due date is typically much earlier than the June 1st RxDC reporting deadline. I know in previous years we've seen like in April or May, which well into April at this point, but from what I understand this year, some deadlines have moved up even further. So a good thing to be aware of or to double check on. Then for self-funded plans, we have the PCORI fee that will be due at the end of July. And then lastly, a gag clause attestation will need to be completed by December 31st. Looking more closely at each of these requirements, we've got some reporting tips to share. Going chronologically here, for the employer reporting, to be clear, there is no extension available for distributing of those forms to employees or covered individuals. But for the submission to the IRS, you can get an automatic 30-day extension if the Form 8809 is filed by the actual deadline, by March 31st, which clearly we're also past that for this year, but maybe something to keep in your back pocket for next year in case you feel like you may need it. In case anyone did need incentive to file these forms timely, there are applicable penalties that can really pile up for failure to file, filing late, or filing incorrect information with the IRS. For 2025, the penalty is $340 per form, and it is capped at about 4.1 million total, but the penalty is applicable per form, and so that penalty may double if there's a failure both to submit it to the IRS and a failure to distribute it to employees or covered individuals timely. So it can essentially double. However, if you do submit or distribute those forms a little bit sooner, the penalty can be reduced down to $60 per form if correct forms are submitted within 30 days of the original deadline, and down to $130 per form if the correct forms are filed by August 1st of the year in which the filing was due. So even if you are late, it can be very advantageous to still get the filing in as soon as you can. Oh, and then lastly here I wanted to touch on was the notice of availability, which is a still relatively new concept just in the last year or two for the Form 1095s, where an employer can satisfy their obligation to distribute the Form 1095 by simply posting a notice of availability of the Form 1095 to a website. That website does need to be accessible to all possible 1095 recipients. And so something like an intranet or benefits enrollment platform that's only accessible to employees may not quite get there, may not be sufficient. But if you do post a notice of availability to a public website by March 2nd, by that distribution deadline, and keep it there until October 15th, including email, address, and phone number that can be used to request a Form 1095, that will satisfy your distribution requirement. And of course, if a 1095 is requested, then then you do actually have to provide that 1095 within 30 days of the request being made. RxDC reporting, I already mentioned that there very well may be a earlier due date than June 1st to be aware of with a service vendor, so that that service vendor takes care of that reporting for you. But if that carrier TPA deadline is missed, then there is some information that an employer will need to submit in order to have a complete RxDC submission. And so they'll need to do what we call a P2D1 filing, just kind of a partial filing for RxDC. And we do have services available for that. I also want to clarify something that we just get asked about a lot, that the RxDC data or reporting looks at data from an entire calendar year. So the upcoming report will include all data from the 2025 calendar year, regardless of when your plan year is, or, so if a plan switched vendors, switched funding mechanisms, switched plan years, all of the 2025 calendar year data will still need to be submitted. And so that may ultimately mean working with multiple vendors just to ensure that all that data does get reported. Form 5500 filings applicable for ERISA plans. And on the screen, we just a few questions to ask to determine whether Form 5500 filing is necessary, and if so, how many. So default rule is that if a plan is subject to ERISA, they may need to file Form 5500. Only ERISA plans would need to file Form 5500. Second question to ask is whether the plan is funded or unfunded. And to be clear, this is a separate, different distinction from whether a plan is fully insured or self-funded. I know that's confusing because they use very similar terminology, but it's a separate characterization of a plan. The majority of plans are unfunded, meaning that plan costs are paid from an employer's general assets, versus a funded plan will have plan assets that are separate or held separately in their own trust or account. And why this is important, then it becomes important when we ask the question, how many participants did a plan have? A funded plan, a funded ERISA plan, will need to file a Form 5500 regardless of the size of the plan or the plan sponsor. Versus an unfunded plan an unfunded ERISA plan will only need to file a 5500 if the plan had 100 or more participants on day one of the plan year. And then lastly, technically, the default rule is that every ERISA benefit would have its own Form 5500 filing, and that feels like a lot. And so an option then is to use a wrap document to bundle all of your ERISA benefits into a single ERISA plan. And when that's done, then you only need a single Form 5500 filing for that wrap plan. So you could go from, 4 different ERISA benefits and four Form 5500 filings down to one. PCORI fees. Some clarity on the deadline for PCORI fees, because this is a fairly common question we get, because it is a little funky. A PCORI fee for a particular plan year will be due on July 31st of the calendar year following the year in which that plan year ends. So another way to say that would be any plan year that ended in 2025, or any self-funded plan that ended in 2025, that plan's PCORI fee will be due this coming July in 2026. It leads to a weird setup where a PCORI fee for a plan may not get submitted until over a year after the plan year ends, but that is in fact how it works. And it's important to understand that because it's also very critical for PCORI fees to always submit them using the correct quarter and the correct year Form 720, which the PCORI fee is submitted on the second quarter Form 720 of the year in which it is due. It's important for a couple of reasons. One, that is the Form 720 that will have the correct PCORI fee listed that would be applicable to that plan year. And if it does get submitted to the IRS in a different quarter or a different year, that it's going to confuse the IRS. They're not going to understand. They may think it's for a prior year. They may think it's late, or the form would have outdated fee information. And so it just gets messy if the PCORI fee is reported on anything other than the correct second quarter Form 720. Gag clause attestations, kind of in contrast, though, like I said, it is ultimately due every year by December 31st. Employers can submit that attestation at any time in the year prior to December 31st. So it can be easiest for folks to just attest or submit this attestation as they go through renewal. Kind of add it to the annual checklist for that time of year, and just look back at those vendors for that plan year, or whenever it makes sense for them. Which, in contrast, the PCORI fee filing doesn't always make sense time-wise, but that's just the way it is. And then for the gag clause attestation, whenever you do go into a test, you are attesting for the entire period of time since the last attestation was submitted, which can be more or less than 12 months. Sometimes we'll get questions about submitting an attestation, quote unquote, late, because it's been more than a year since their last attestation, but it is not late so long as that gag clause attestation is being submitted at some point in the year, each year before December 31st. That'll be timely and compliant. Right, I'm going to hand it over to Regan now to look at some compliance review items for the year.
Right, thanks, Delaney. Hello, everyone. Spring cleaning, nice. Delaney just kind of took us through the things we have to do for the rest of the year and make sure that we're reporting and handling. We always know that there's kind of a wish list when we have a lull, or we just, kind of take a breath and try and do some of those other things that might be on the list. We don't have a specific deadline. We don't have something that we have to turn in somewhere, but things that we just know are kind of best practices. And so those are some of the things that I just want to bring up right now, things that we think you should be kind of thinking about if you haven't historically, or that it's good to just do once a year. So starting off, plan documentation. We've been talking about this a lot just in light of all the ERISA fiduciary claims and things that have been going on, and just the importance of having that plan documentation in place, because that's really what we communicate all the participants' rights and responsibilities in, as well as give kind of you as the employers and our administrators and service providers, we're supposed to all be following that documentation in administering the plan. And so it's important to have that in place, and it's important to keep it up to date. We don't have to do a brand new plan document in SPD every year. That's not a requirement. We don't even have to distribute it every year. The requirements are when individuals are first eligible, and then at least every 5 years with all the updated changes. But best practice is really to pause and look at this at least once a year and make sure that we've got things correctly captured. Do we have the right benefits still listed in the plan document or the wrap document? Do we have all the underlying certificates of coverage and summaries of benefits? Do we have eligibility rules that match the way that we're administering the plans? Do we have a cafeteria plan documentation formally adopted and in place that allows us to handle employee contributions on a pre-tax basis? These are things that we can even put them in place and adopt them effective back to the beginning of the year if we need to. If you've been making changes, you've been putting out summaries of material modifications or doing some amendments, we can take those and kind of clean up and incorporate them into a restated plan document. But just important to make sure that that reflects what's actually happening with the plan administration. Going right along with that are our eligibility rules. And so often what we find is that the eligibility rules as drafted are vague in our plan documentation. They may not even say a specific hours requirement, or they may have just kind of a general definition that doesn't match and differs from different benefit offerings or between different classes of employees. May not be super clear on how we measure full-time status. For example, are you using the monthly or the look-back measurement method? So it's a good idea to have that captured. And if it's not in the plan documentation, that it references other documentation where you've got that and you can point to it, and you know if you have questions that come up, how you're supposed to be following those. And it's not important just for employees, but it's also important for spouses, domestic partners, if you've decided to extend eligibility to them, and other dependents and legal guardians. How are those defined? What types of requirements do they have to meet? What types of documentation do you require, if any? Or do you just rely on the employee's attestation? Again, this is another area where oftentimes we're just kind of relying on templated language that we're given or something from the carrier or TPA, and it doesn't match or isn't detailed enough to give you what you need to do if questions come up around eligibility. So just making sure that you've got those correctly captured somewhere so that you're clear and you're able to communicate that to employees. Then again, kind of similarly, continuing along the same lines, whether it's in plan documentation or it's an employee handbook, what about leaves of absence? Oftentimes, employers are getting better and better about documenting what happens under a protected leave or state paid leave, or even under unprotected leave. You may have policies and procedures that you allow employees, if they get it approved with HR, to go out on an unpaid and unprotected, could be both, leave of absence for a period of time. What's often missing is how benefits get handled. Are the employees still eligible for benefits during that time? If it's state or protected leave, the answer is probably yes, and you don't have any choice, at least for your group health plan benefits. But for other leaves, that isn't the case. It really is up to your policies. And if you don't have that defined, it leaves you in a tough spot when that happens, understanding when you can terminate their active coverage and flip it over to COBRA continuation or state continuation. So take a look at your leave of absence language. See if it just talks about the leave of absence itself and kind of the reinstatement of employment, or does it go on and dictate what happens with benefit eligibility as well? And then make sure that you think about, for unpaid leave especially, how do employee contributions get handled? Are you collecting those while they're out on leave? Are you allowing catch-up contributions upon return? Do you give yourself some room in your language to terminate coverage if non-payment occurs? Those are all things that, again, we just often find are not clearly defined anywhere. And then employers, when they're in the middle of a leave of absence and they don't have that to follow, it's hard for them to know what to do. It's also hard for them to give something to employees to communicate what the plan expectations are. Two different kinds of kind of testing or documentation that we recommend that you're doing for your plans. We know that a lot of vendors have been sending out reminders to do non-discrimination testing. The reason why they're doing that kind of this time of year is once you've put the plan in place, you understand who's chosen to participate in your plan or waive the plan and at what amounts they're choosing to participate. That's the appropriate time to run discrimination testing. We've got a bunch of different types of testing that's done under different rules, depending on whether it's a cafeteria plan, a self-funded plan, dependent care plan, or group life plan. Running that testing to make sure that we're not overly favoring highly compensated or key employees, and giving yourselves enough time to make corrections if needed, to adjust how much those highly compensated or key employees are participating on a tax-favored basis before you get to the end of the plan year. Because if we make those adjustments within the plan year and ultimately get it to a place where we have a passing test result by the end of the plan year, then we don't put that tax-favored status at risk for the highly compensated or key employees. If we don't do that testing until after the end of the plan year, then we really aren't permitted to make those types of corrections. Mental Health Parity and Addiction Equity Act, we are required in general to have plans that are designed to provide mental health and substance use disorder benefits in parity with what is available for medical surgical benefits. We are supposed to have that be in parity both as written and in operation. To understand kind of the operations piece of it and make sure that that's okay, it requires some level of an analysis. You can do it for the quantitative treatment limitations, like your financial restrictions, or quantitative treatment limitations, like visit limitations. We can also do it on the non-quantitative treatment limitations. That's the NQTLs. Think of medical necessity, prior authorization, exclusions. Those are things that we can't just look at numbers. We have to do more of kind of a facts and circumstances and look at ultimately how the claims are being processed and how that's coming out to understand if the plan is really in parity. They put in the Congress passed via legislation, so it's officially in federal statute that we have to do a written comparative analysis for the plan and have that on hand and be ready to hand it over very quickly if audited by the federal or state government, or if for an ERISA plan, if plan participants request it, we're supposed to be able to turn that over within 30 days. So this isn't something that you have to do and send in somewhere, but it's supposed to be something that you have done, you keep it current and have it available upon request. Lots of confusion around this. When they pulled back the 2024 final rules from the agencies, many misunderstood that this requirement went away, but that's not the case. Some of the clarification about how it should be laid out, maybe some of the content that should be in the analysis, that went away. We can no longer rely on that, and we're waiting for further guidance. But the requirement itself was passed by Congress and is in our statutes, and so that does still exist. Then final couple things, just to keep in mind, if you don't already know whether you have entities that are related to you by common ownership or kind of shared management and services, how they are related or whether they are considered to be part of a controlled group or an affiliated service group in accordance with IRS rules can really matter for how we apply a lot of the different benefit compliance rules. For example, controlled groups, entities even with separate EINs, if they have 80% or more common ownership, then they're viewed as a single employer for most benefit compliance purposes, and they can even share benefit plans as a single employer if they want to. But if we have entities that are related but not related enough, something less than 80% or more common ownership, then they are separate. And if they try and share benefit plans, it forms what's called a multiple employer welfare arrangement, a MIWA. That's not impossible. It's okay in some instances to form a MIWA and to operate and administer a MIWA, but it's subject to more compliance requirements. It's harder to do in the self-funded space. So we just have to be careful of that. And we can really stay away from that if we only have entities that are controlled group that are sharing benefit plans. Important to note, affiliated service groups, that's another kind of type of grouping under IRS rules where they may not have 80% or more common ownership, but they have a certain level of common ownership, or they share management and services amongst them. Those types of groups, for a lot of purposes, non-discrimination rules, whether they're an applicable large employer, they get combined. But if they aren't a controlled group, they aren't able to share benefit plans without forming a MIWA. Finally, taxation of benefits. This is, again, just kind of double checking to make sure that you're doing everything, you have it set up correctly through payroll before we get too far into your plan year, and it gets harder and harder then to make corrections if needed. Making sure that you're properly taxing non-employees. So owners, independent contractors, and domestic partners, they can potentially participate in your benefits if you include them as eligible, but they can't participate on the same tax-favored basis. We have to handle any of their any of their contributions after tax if they're making contributions toward the benefits, and then any company contributions would have to be included in their taxable income. Similarly, be careful with your different benefits. A lot of the benefits that employers are offering can be handled on a tax-favored basis and excluded from income taxes, and then don't come into payroll taxes for the employer as well. But that's not the case for all of them, or they may only be able to provide a portion of them on a tax-favored basis. So just go through and make sure that you've got everything set up correctly, depending on who you're offering benefits to and what makes up your benefit package. All right, so that was kind of our spring cleaning, our list, those things that you should just take a second when you have a breath to look at and make sure that you've got those handled. But now we want to focus the last portion of our session today on compliance changes that we're watching, that we think that you should be watching and kind of paying attention to see what happens now over the rest of 2026. So the first one is watching, I mentioned it earlier, a lot of the ERISA fiduciary litigation that has really been taking off and focused heavily on health and welfare benefits. This is something they were focused on retirement plans historically, and now they're moving on and they're really focusing kind of similar ideas and claims against health and welfare benefits. During 2024 and 2025, we saw a lot of the claims that were related to pharmacy benefit managers, to PBMs, selecting those, whether they were, and then the related fiduciary responsibilities, kind of monitoring those and the fees that were being paid in connection with those. Then in 2026, just at the beginning of this year, we saw several claims get filed, similar types of claims. So I've got the allegations there kind of listed at the bottom, same types of things that they were upset about, but really targeting voluntary benefits and even pulling in brokers to some extent in kind of their role in negotiating and putting those in place. So really important that employers are careful and thinking about when they're selecting service providers in connection with their plan, especially for self-funded plans where you have more flexibility to pick and choose the different pieces that you're putting in place to administer the plan. What's your process for selecting those vendors? And then once they're in place, how do you monitor them and make sure that they're really living up to what they're supposed to and serving the best interests of your plan participants? The fees that are paid, whether it's kind of directly to these vendors, whether the plan participants are picking up a portion of that, whether it's ultimately kind of how they're setting fees and things within the plan and the way that it's being administered, are they reasonable and fair? Doesn't necessarily have to be lowest cost, but does it make sense kind of for what they're getting and with what's available when you're benchmarking with the industry? And it's important for employers, either themselves or make sure that they've got advisors that are helping them to make sure that that is the case. And then finally, conflicts of interest, just different relationships, or if the employer is benefiting in some way because they're putting certain vendors in place, just being really careful of that, because ultimately we're supposed to be making sure that what we're putting in place and the package of things, especially because we're often collecting employee dollars to make it all happen, that it's all in the best interests of those plan participants. So when we think about ERISA fiduciary duties, we've got a list of things here, and hopefully this kind of helps just highlight what the expectations are. Employers are not expected to get everything perfect. There's a realization that employers are running their businesses. Benefits are a secondary piece of just what they're trying to make available to their employees, and that they're going to need help, and they're going to make mistakes along the way. But the idea is that you're always doing it in a way that you're acting solely in the best interest of plan participants, that you're gathering enough information that you can make kind of reasonable, thoughtful decisions, pull in advisors where appropriate, and then document those decisions so that ultimately down the road, if it doesn't play out in the way that you expected, you can show why those decisions were made in the first place and potentially defend yourself, even if it plays out in an unexpected way that maybe isn't in the way that your plan participants are happy with. And so these are just kind of the key things that ERISA fiduciaries should be thinking about, or employer plan sponsors. You're kind of the default ERISA fiduciary for your plans, making sure that you're following these for all of your ERISA covered benefits, which is most of them. The next set of lawsuits that we've been watching are the tobacco surcharge lawsuits. These continue to target tobacco surcharge programs where employers are charging a slightly higher premium or employee contribution for those who are tobacco users. Those are a flavor of wellness programs that are subject to HIPAA wellness rules. And the allegations here is that those rules aren't being followed, that in some cases a reasonable alternative standard isn't provided, those cessation counseling programs or use of cessation products, that notice of the reasonable alternative standard, even if it is available, wasn't really given, so participants didn't have a way to know that they could take advantage of that. And then kind of the final wave of cases that we've been seeing more often is maybe the reasonable alternative standard was provided, maybe it was even communicated, but for those who satisfied it, they didn't get the full reward back to the beginning of the plan year. They might just remove the surcharge on a prospective basis, which they're arguing is not in alignment with the HIPAA wellness rules. So we've got an illustration here of the kind of these key requirements. The main ones for HIPAA health contingent programs, which includes tobacco surcharges, is around incentive limits. For tobacco specifically, it can't be that either the penalty or the incentive, whichever way you want to look at it, can't be more than 50% for tobacco-related programs. And then we have to provide this reasonable alternative standard and make sure that that is communicated, that participants know if you're a tobacco user, for example, that you can take advantage of and satisfy and get that lower rate by satisfying a reasonable alternative standard instead. And the DOL guidance is very clear that we're supposed to get the benefit of satisfying that reasonable alternative standard all the way back to the beginning of when the employee kind of first enrolled in the plan at the beginning of the plan year. If they came in mid-year, if a surcharge applied, that would get removed retroactively if they satisfy the reasonable alternative standard within kind of the time frame set by the plan. Not all employers are doing that. Interestingly, as we're watching these cases, and there have been a ton, a lot of them settled, and so then we don't know kind of how the court would have decided, but some of the early cases that we did get a court decision, they were going mostly in the favor of employees and aligning with the DOL guidance. But more recent case decisions, and there have been several of them, have been siding in favor of the employer, and the employers only providing the removal of the surcharge on a prospective basis have been kind of getting away from that. What's ultimately happening is they're bringing in these cases under ERISA and then not having a lot of success on their breach of fiduciary duty claims. So they're not even necessarily getting to kind of whether these health contingent rules work or not. But it'll be interesting to see. For now, we're certainly still recommending that you follow the DOL's guidance and make sure that you're following the incentive limits and the reasonable alternative standard requirements and giving the full reward back to the beginning of the year. But just a place to watch as we have employers kind of questioning what flexibility they have here in running these type of tobacco surcharge programs. Another thing that we're really watching and moving away from litigation is the individual coverage HRA trends. And we continue to hear more and more about these as more employers are exploring these. Small employers continuing to adopt these. You can kind of see on the right, it's small and large employers and kind of adoption between 2020 and 2025. I know there's a lot of information on the small graphic, but just showing that it's growing year over year. Also on the left side, just looking, early on, it was kind of primarily small employers. Maybe they hadn't offered coverage before. Maybe they struggled to afford a plan. Maybe they struggled with participation. And so an ICHRA or QSARA wasn't a good potential option. But you can see on the left, we're starting to see more and more large employers adopt ICHRAs. Not very often are we seeing employers move completely to ICHRA offerings, but there is some flexibility to do them by class of employees. They give us specified classes. And so that's where we're seeing more and more large employers have this be part of the mix of what they're offering in their benefit package. So with that, kind of understanding the high-level requirements for ICHRAs is important. It can't be offered to those who are also offered a traditional group health plan. You can't give employees a choice between the two. So once you decide which classes are going to get which, within a class, that class either gets an ICHRA or a traditional group health plan, and they can't have a choice between the two. To have access to the ICHRA reimbursement, it is a flavor of HRA, so it's an employer-funded reimbursement. It's only available to those individuals who then attest to having either individual health insurance or Medicare. So it's not available to be paired along with a spouse's plan or with another employer's plan. It is available only to those who have individual coverage or Medicare. I mentioned already it has to be funded solely by the employer. And then when the employer is deciding how much to fund, that has to be uniform by class of employees. Again, they give us the specified classes. Within a particular class, the only variation we can have is by age and tier of coverage. There is an annual notice requirement to let employees know what the ICHRA is, how it works, how it pairs with individual coverage, and how it interacts with premium tax credits if they're going through the marketplace. So it's important to make sure there's that separate specific notice that goes alongside an ICHRA. And then finally, and perhaps most importantly for large employers, applicable large employers have to offer minimum value affordable coverage to full-time employees. The ICHRA can satisfy those requirements. If it's designed to be affordable, then it can satisfy the 4980 A and B requirements. And that's where there is some flexibility for larger employers to offer the ICHRA to full-time employees if they want to, or at least a portion of their full-time employees. So if we look at kind of some of the strategies of where might this be a good fit, or which employers might be thinking about this, you can see on the right, and I mentioned a few of them on the first slide, but median minimum participation requirements, if employers are struggling with that, maybe they do an ICHRA instead, because an ICHRA wouldn't have those participation requirements. If you've got an employer with a class of employees where there's a lot of high turnover or variable hour employees, maybe the ICHRA is a good solution. It's an option for something to offer to part-time employees if they're not already being offered something. Maybe it's better. Some employers are offering a MEC plan, a skinny plan, or a limited medical plan. Maybe an ICHRA would be more attractive than that. Plans with high claims experience, that's another place where they're just exploring options. Would it make sense to offer an ICHRA to at least a portion of the population and try and capture as many of those high claimants as they can in that particular class? Employers who have lots of Medicare eligible employees, I want to be really careful with this one because you cannot offer an ICHRA only to Medicare eligible employees, but you could be kind of clever with the classes that we can use and make sure that most of the Medicare eligible employees fall within that class, and use an ICHRA in that way. And then finally, the place where we're perhaps seeing it most often is a lot of employers will have a bulk of their employees in a particular area, and maybe they're designing their plan and the network for those employees, and then they hire a handful of remote employees, and the plan just doesn't make sense for them. Well, rather than trying to expand what they have to make it a more national coverage or put another plan in place, maybe they offer an ICHRA just to those remote employees that are working in other states, and that would be one way that they could do that. Potential kind of benefits versus issues on ICHRAs. But benefit is that employers are not responsible for plan design. They kind of get out of that. Individuals go and pick their own individual plan or Medicare, more predictable budget because the employer is saying this is what we're willing to fund in the HRA or the ICHRA each month. A little bit less compliance and administrative responsibility, but it certainly doesn't go away completely. For employees, a little bit more flexibility in plan choice and able to maintain that plan. They can keep that with them as they go from one job to the next if they want, because it's only the ICHRA that's tied to the employer. That individual plan is their own. Potential issues that we've seen is it does require some education and change for employees. It is very different than the traditional group health plan model. And so from an employee relations standpoint, to make it successful, it's really important to make sure that there's good education and kind of assistance around that transition. It also can make it a lot harder. There are certain areas in the country where network and what's available via individual plans just isn't as good as what might be available in the group health plan market. So that can make it a hard transition. And then there also can, just from an administrative standpoint, be some issues with timing of reimbursement and handling reimbursements and less flexibility. The employer is not always going to be able to work directly with the carriers to be able to add or terminate coverage and make sure that aligns with their ICHRA reimbursement. So that can just make it a little bit tough. All right, Delaney, back to you for the last couple things.
Right. Thanks, Regan. Last couple of things that I'll touch on. Just in February, we got the Consolidated Appropriations Act of 2026, and they had some pretty big changes for pharmacy benefit managers and how they operate in the group health plan market, specifically around new requirements to report to plans semi-annually, including just plan level summaries for plan fiduciaries. Larger self-funded plans would also be entitled to even more detailed reporting under that. And then that came with pretty steep penalties if the PBM does not comply, up to $10,000 a day. And then there was also rebate remittance. PBMs will now be required to remit 100% of any rebate, discount, whatever you want to call it, that they'll have to pass through 100% of that rebate back to the plans. And for self-funded plans, that means it'll come back to the plan. For fully insured plans, that means it'll come back to the carrier. And then plans would also have the right to audit as to the rebate annually, just to ensure that the PBM is doing what they're supposed to on that end. Transparency, a new transparency requirement for PBMs. The kind of a gag clause prohibition that we're familiar with for group health plans will now be in place for PBMs, where PBMs will be prohibited from entering into a contract with drug manufacturers or really any entity in the prescription drug supply chain that would limit their ability to provide this reporting that or disclosures that will now be required of PBMs to their plan and issuer clients. This is exciting, these new requirements for PBMs, but the effective date will not be for a while. It's technically 30 months after enactment of the act that was in February. And so that won't be until PBM contracts and plan years that begin in 2029. And we do expect there to be more guidance forthcoming well before that in the next 18 months. Regulations just further describing exactly how these requirements are going to be executed by PBMs. Also part of the Consolidated Appropriations Act from 2026, expansion of the compensation disclosure. You may be familiar with brokers being required to disclose their direct and indirect compensation. What the CAA did was expand this requirement to basically all service providers of a plan that expect to receive $1,000 or more in compensation. And so have to disclose certain information before they enter into or renew a contract. And in contrast, the effective date for this requirement seems to be upon enactment, upon immediate, really. So whenever you renew a contract now, that this will be something to bring up. Because overall, the takeaway for a plan sponsor from the Consolidated Appropriations Act will be that this is going to create a lot of access to information that will be necessary to get your hands on to properly execute your fiduciary duty, kind of what Regan was talking about, where you have a fiduciary duty to review compensation and have overall oversight of these service providers. And what the CAA is doing is just providing more information for plan sponsors to be able to rely on in making those decisions. Medicare Part D, creditable coverage, you may be aware, group health plans they are not required to provide creditable coverage, but they do need to determine whether their prescription drug coverage is creditable or not creditable and communicate that status with their participants. Traditionally, there's been two methods for determining creditability: actuarial and a simplified determination method. 1 or 2 years ago, the CMS revised the simplified method, and so for 2026 and I think 2025, there were actually three methods available: actuarial, the original simplified, and the revised simplified. And so you had your choice of the three. But recently, CMS came out with a final rule that is clarifying that for 2027, the original simplified method will no longer be available. So you will have to use the revised simplified method or an actuarial method for purposes of determining creditability. Then also part of that final rule that CMS released that I just mentioned, they blessedly clarified that account-based plans do not have to provide this creditable coverage notice or reporting to CMS of their creditable status. For health FSAs and HSAs, for both of those, for different reasons, they really didn't have to comply with this anyways, but this is really the biggest news for HRAs, particularly ICHRAs, where technically those are self-funded health plans that would have this requirement apply, but not totally make sense. Just because of how they're designed, but now we have clarity that those things do not need to report their creditable coverage, both to CMS or to their participants. And then lastly here, well over a year ago, January 2025, CMS released a proposed rule to change the HIPAA security rule. And they've kind of been sitting on it since. They've just been proposed rules. There are no changes that are finalized or effective at all since then. But the reason we're bringing it up now, though, is that we've seen that these proposed changes are now on OCR. OCR is the Office of Civil Rights. That is the HIPAA enforcement agency under HHS. And as part of the regulatory agenda for this coming May, they have these proposed changes on their agenda. And so we may expect to see some finalized versions of these rules come out as a result of that. Can't say if or when that would happen or what those finalized rules would look like compared to the proposed rules, but it's a possibility, something to keep your eye on, and just to put anybody to rest or anybody's concerns to rest. If they do come out with finalized rules, covered entities, including health plans, would have at least 240 days, well over half a year, to comply with any of those changes. And with that, I'll turn it over to Jenny and the remaining polls.
Great. Thank you, Regan. We covered a lot today, so appreciate you and appreciate your insights today. We have a couple of polls left here. If you're with us at the top of the hour, you answered a couple of polling questions for us on the topic of benefit inequities. We have a couple questions left here also on that topic. The first one around what is the biggest barrier to improving benefit equity in your organization? So please take a moment and answer that question. And if you scroll down a little bit, you'll also see a follow-up question. What aspect of your current plan design contributes most to benefits inequity today? So thank you for taking a moment to provide your responses to those questions. And as you are submitting those responses, I will remind you again, we did record today's session. So if you are looking for a link to the recording to today's presentation, you can get that from the benefits advisor who invited you here today. They will also be able to provide you with a copy of the presentation slides if you didn't get a chance to grab those earlier. And if you did want to dig in more to any of the various topics that we covered here today, your benefits advisor would also be the place to go to dig in more onto any of these topics and to discuss those further. And again, we would also like to thank those benefits advisors and consultants who are partners of Assurex Global for making this webinar series possible. We'll let these responses come in here for our last few seconds here so we can see how everyone is feeling about these questions. Sneak preview would say the biggest barrier would be cost constraints. And the aspect that contributes most to benefits inequity would be the employee cost share premiums. I don't think I'm too surprised about either question, but it's always good to get your perspective. So we certainly appreciate you taking a moment to respond to these two polling questions. So I will share those final responses out. And again, as a reminder, we do publish the results from these polls into a document we call a market check survey that comes out every single month. It shows the full responses to these polls as well as a write-up on our perspectives of what these means and some different considerations for your organization as you kind of think about these topics. So keep an eye out for that market check survey to be published here in the next week or so. But with that, that does conclude our time together today. I want to thank Regan and Delaney again for their time, and to our audience, thanks again for tuning in, and have a wonderful afternoon. Thank you.